Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hey, it's my great pleasure to welcome Professor Tammy Hoffman to the Glenohumeral Gurus podcast. Tammy, welcome and thank you for your time.
Thank you.
So I reached out to Tammy because I wanted to know more around shared decision making. And before we move into that space, Tammy, can you describe your career for us, what your background is, what you're doing at the minute, how it is you got to be talking to me about shared decision making on a shoulder podcast?
Thanks. So my current position is I'm Professor of Clinical Epidemiology, which just means evidence-based practice, at the Institute for Evidence-Based Healthcare at Bond University on the Gold Coast in Australia. So my clinical background, a very long time ago, was as an occupational therapist.
Okay.
And so I worked in particularly rehab for a while, and then I did a PhD in stroke, but in kind of patient education and health communication. That was one of my areas of interest. But then I also had a parallel interest in evidence-based practice. And I was part of the team that initially developed OT Seeker, which is an evidence database like Pedro, physio, but the OT equivalent. And we worked with the Pedro folk to set that up decades ago now. So I sort of had these two parallel interests of evidence-based healthcare and how to get evidence to clinicians. And then I was interested in patient education and health communication and how we engage patients in making decisions about their health. So after a while, it became apparent to me that they weren't, while they were parallel areas of research interest, they actually overlap. Yeah, that's right. And so once the clinicians know the evidence, they have a responsibility to talk with the patients about it and share that evidence in a way patients can understand to help them make their decision. And so that is essentially what shared decision making is. And I think because I always had a foot in both camps, that was really obvious to me that you needed the skills in healthcare communication, everything that goes with that, as well as a good understanding of how to find evidence, how to appraise it, how to understand statistics like the risk data, how to communicate that clearly, and how to bring the two together with the patient and help them make a patient-centered evidence-based decision. But because it turned out, the more I sort of went into that space, that most shared decision-making research was being done mostly by folk, often psychology backgrounds or sort of health communication backgrounds, but without the EBM focus. And most research in evidence-based practice was stopping at that bit of finding and appraising the evidence, that fourth step of evidence-based practice. How do I apply this to the patient, which is the original terminology, was kind of getting glossed over and seen as, not so, there hadn't been much done in that space. So where those two come together is very much shared decision making. And so, yeah, that's where for the last 20 or so years, I've been devoting a lot of my time and effort into teaching it and researching it and developing resources and sharing the world. And yeah, now I think the shared decision making community, it's very clear to everyone now, and it's obviously not just my doing, but that this is a big part of it, and communication skills is a big part of it, and you need both. And we wrote a paper over 10 years ago now in JAMA that kind of summarized that up really neatly with a really simple figure with just the 3 circles saying you need skills in for optimal healthcare. And a lot of people went, oh, okay, yeah, hadn't thought about it before. Now I get it.
Yeah, and so you see that happening. Yeah, no, that's a wonderful story. I always enjoy hearing people's stories to how they get there, because like you say, these two interests are quite parallel and really are sort of blended in that process, which is where you are.
Yeah, I'd always thought of them as quite distinct way back, decades ago. But yeah, it actually turns out they're more connected than what I'd originally thought, which was convenient, I guess.
Very nice. Yeah, no, it's great.
So yes, and now I do shared decision making work across lots of clinical areas. So
Yeah, great. So as I explained to you in our emails, my particular interest is in shoulder, particularly shoulder instability and using shared decision making in that process. But before we get to that, can you outline for people what shared decision making is? What are some key fundamental concepts that exist? What should clinicians know about what we're talking about?
yeah, so shared decision making is a process that clinicians can use to try to engage patients to collaboratively make a decision, an evidence-informed decision about their healthcare. So it's not some kind of add-on step you do at the end of a consult, but it's actually a way of kind of structuring or configuring the consult so that from the outset it's clear that the patient's clear that there's a decision to be made, and that they are invited and encouraged to participate in making that decision in conjunction with their clinician. So of course, you don't want the patient to feel abandoned, like, it's all on them and they're unsupported, but it's making it clear there's a decision to be made. There are some options, I'll work with you to talk through what's the best option for you. So that's sort of initially sort of setting the scene, I guess, in the consult about making it clear there is a decision, because a lot of patients think that health professionals know everything, which we know is far from the truth, and that there's one clear way to treat everything or to test, and they don't realize that a lot of healthcare operates in a grey area where there's a lot of uncertainty, there's a lot of options, and that there's no one superior way forward for the majority of health conditions.
And do you think so clinicians should set that up at the beginning of the sessions, or in particular patients that they work with, to let patients know about that? That's what you're saying.
It's to say, there's a number of ways, that we could approach managing this. I guess I'll probably talk most of my responses in terms of a treatment decision. Obviously, shared decision making applies to testing decisions and screening decisions and all of those as well. But if we're talking about a treatment decision, being upfront with patients that, there are some options, and I'd like you to be, if you'd like, I'd like you to be involved in making the decisions about what's best for you in conjunction with me. So it's just setting the fact that there are options.
Yeah, and what do clinicians do when they're like, "Will you tell me what to do?" Because I've tried to set the scene like this, okay, let's engage in this process, and then they're like, "Well, you tell me what to do. You know best."
Yeah, absolutely, and that comes up often, and I think what often clinicians are encouraged to do is say, well, this is not about, I'm not you. I have different values and preferences, and what matters to me may be different to what matters to you. Some clinicians will say, if it was me, I would do this, but I guess it depends on your relationship with the patient, and you can certainly sort of, if it was me, I would, but it's good to acknowledge that your values and preferences and what matters to you is different to what matters to your patient.
And do you have any tips to try and then counter, because patients, everybody has bias, eh? All clinicians have a clinical bias. Do you have any tips for clinicians to counter their clinical bias? Do you have any thoughts around that? Because
I mean, I guess both parties in that decision making have bias. So patients will come into a consult with bias about, and that's often expectations about what they need, and they may have read it somewhere, they may have Googled it, they may have had a friend or a neighbor say, when I had this problem, so and so, got treated with this, and that's what I need. So patients come into a consult often with expectations, and we know that expectations can lead to a clinician providing something, even if the clinician thinks it's not clinically recommended. There's lots of literature documenting that. But we know clinicians bring their own biases into a consult, and it may be that they have a preferred treatment option, or they have and some of the work we've done is looking at both patients and clinicians' expectations of the benefits and harms of interventions. And we did this 2 huge systematic reviews across all clinical areas, so every test, treatment, screen, where the research had been done. And we found that in the majority of cases, most patients and most clinicians overestimate the benefits of treatments and they underestimate the harms. So we have a sort of a therapeutic bias. We think that things are going to help more than they actually do, and we think things are going to harm less than they actually do. So, and that's where the clinicians knowing the evidence comes into it, because you've got to check your own, oh, well, you know, I've always provided this treatment and all my patients get better on it.
Yes.
But, you know, that's often not the case. It's checking it. What does the evidence say about what's the likely size of the benefit for this intervention? What's the likely size of the harm? And I should say by harms, we don't just mean side effects, which is often, you know, what people think of, but think of everything as what's the pro and the con. So the con might be the cost of treatment, you know, the inconvenience of the number of sessions and how the person has to take time off work, or, you know, travel, or rearrange their life and their childcare and everything else to fit in. So it's it might be time off work. So it's any downside to that treatment. So it's important that when a patient's considering treatment options, it's the weighing up the, you know, what benefit am I likely to get out of that? Does that match the expectation I have of it? You know, so is 2 points improvement on a 10-point scale for pain or function or whatever, is that enough that I think the treatment's worthwhile? And how, when I weigh that up against, you know, all the downsides, like the cost and the inconvenience, etc., how does that weigh up for me?
And so, as a broad framework, because we talked briefly about frameworks before we came on air, and as a broad framework, you're saying, like, what are the pros of this? First of all, there's a decision to be made, and then what are the pros and the cons of each of those decisions?
Yeah, absolutely. So the key steps in shared decision-making process is highlighting that there's a decision to be made, and then going through, well, here are the options, the main options, and it depends on the decision, of course. For some decisions, there might only be 2 options, so that's a bit more straightforward. For others, there might be, you know, half a dozen, and you may wish to, in that case, sort of go through, just list the main options and say, are there any of those that you would not be interested in? So, for example, surgery, a patient may say, no, I'd never bother having surgery for this, don't want to hear more about that. But presenting that there's options, and then for each option going through, what are the benefits, what are the harms, and that involves communicating the evidence, the likely size of the benefit and harm, and then helping the patient to weigh up, well, how do these benefits and harms weigh up for me? Which option might be the best option for me at this point in time? And then checking that do I have enough information to make a decision? Or because most decisions, other than emergency situations, aren't urgent. People can decide to defer the decision while they, you know, reflect or read up more information that the clinician might give them, or talk with family or friends, or so a plan for sort of, do I have enough information to make a decision, or should I postpone this for a bit?
Yeah, and so, because similarly in the space that I work in shoulder rehab, like you say, it's not life-threatening injuries. There is time to reflect, and I think why I wanted to connect with you was to see what I could learn that would enhance my clinical practice, because I think I'm telling people there's an option and helping them guide about the decision. But what I'm probably not doing is reflecting back with them to say, do you now have enough information to make that decision? That's an important end step, isn't it?
And I mean, people feel the pressure to decide and to do something then and there. That's the desire to do, and clinicians feel that. That's one clinician bias, is the desire to do something to help people. And that's why people become health professionals. We want to help, but it's that kind of desire to help, even if helping at that point in time may not be either the best option for that patient at that point in time, which I should probably point out, going back to listing what the options are, and I don't know if it's always appropriate in the patients you see, but one option often is the wait and watch. So particularly for spontaneously remitting conditions. So, and, you know, obviously a lot of musculoskeletal conditions do get better on their own. Just the natural history of it is that, you know, give it a few weeks or a few months and it will improve. So presenting the option of the terminology is tricky. There's no agreed upon best terminology. Like, it used to be called do nothing, but we've done some research showing that patients feel a bit slighted, and rightly so, and uncared for if you call it a do nothing approach. So, you know, it can be called no active intervention, or wait and watch, and just sort of a wait and see approach, particularly if you're weighing up things like, you know, surgery versus no surgery. You may not want to rush down the surgical path because it's irreversible before you wait and see if over time, or with a non-surgical approach like physiotherapy, for example, does it improve? Does the condition improve significantly enough that I no longer want to consider surgery as an option? So I think where it's applicable, and it's obviously not applicable in every scenario, but if a wait and see approach is appropriate, that should be listed as an explicit option.
So that people understand that that is an option, and they're not, first of all, not being neglected.
Exactly.
But also that's actually a choice, isn't it?
And it doesn't discount, you know, taking pain relief medication or doing all those things at that point in time. It's just in terms of you're choosing at that point in time to not do an active intervention. And that you can revisit, they can revisit that decision at any point in time. If, you know, 2-3 months down the track, they're still, you know, they haven't noticed any improvement, and now they want to explore active intervention options, that's absolutely fine. But some people, not everyone, but there's that bias towards that more healthcare is better, which is often not the case. And that leads us into the whole overdiagnosis, overtreatment problems.
But again, that comes from bias as a human, isn't it? It's a similar, you know.
It's the wanting to help. It's the thinking.
Yes.
It's all of those biases, you know, as long as before we even get into the more tangible ones like financial incentives and all of those things.
Yes. And so I guess what I've just learned from you now is actually just having those discussions and then giving people the space to make the decision, not necessarily in my treatment room, but to ponder on later and to come back with me. That's probably a better approach, isn't it? Because it gives people time to consider all those factors.
Absolutely. And if there's, we know that people forget at least half of what they're told in their consult. So if there's any written information or any type of patient resources, like obviously patient decision aids are what are usually used to support decision making where they exist, that they can take that information away and ponder on it.
I was looking around patient decision aids as I was thinking about our talk, and I think the ones that are available are quite limited and not so much in the shoulder space. In terms of developing a patient decision aid, that comes from looking, you've done some work then, haven't you? I was just reading a qualitative mixed method study that you'd done.
Yeah, and it's becoming an increasing area of interest among physiotherapists. So I work with a few teams that, there are more and more physio patient decision aids appearing, which is fantastic.
Okay, so maybe I can put a link then for people to be accessing, because it helps, it makes that process easy. Do you want to explain maybe what decision aids are, how they work, how clinicians can use them?
So a decision aid has I mean, the shorter the better usually. You know, a few pages is fine, but basically it's the steps of the shared decision-making process. What's the decision that needs to be made? It lists the options. It presents the benefits and the harms, and where there's evidence to guide, to communicate, it, you know, might have a pictogram, you know, showing sort of 4 out of 100 people will experience this benefit by, you know, this time frame. So clear presentation of the size of the benefit, the size of the
Mm-hmm.
harms, also lists there's other kind of cons I spoke about, like, this is how much time you need off work, or people normally need, this number of treatment sessions. And then some prompt questions, often they're called value clarification exercises, but,
Okay.
how do I feel about, the pros and cons of these options, and how have I thought about how this might impact on my life, and sort of just a few prompt questions to get folk to think about what it all means for them. And then, are there other questions I'd like to ask my health professional, or do I have enough information to make a decision? So it's basically what you would say verbally in a shared decision-making consult, but it's just in a written form. And we know that visually presenting information can make it easier for people to sort of comprehend and also recall after the consult and discuss with others.
Yeah. So the space where I have been using this approach is I work a lot in shoulder instability, helping young athletes who've had a dislocation, whether they have physiotherapy or surgery. So I work to kind of guide them in that space. And I've also been using this approach, helping athletes decide if they're ready to go back to sport after an injury. In that space, I guess the other thing that came to mind while I was talking with you was patients with a frozen shoulder, helping them decide what their treatment process is. Will they have an injection? Will they not have an injection? Those kind of, which leans into their values a bit. In those spaces, I guess maybe we pick the return to sport thing. If you're dealing with a young athlete who wants to go back to sport, and there's a number of things that you can do from an evidence point of view, but is there anything you think clinicians should think about, or is specifically different in that for shared decision making, or the same processes apply?
The same processes would apply. I guess in that type of decision, there may not be huge amounts of evidence to put into the decision made. I mean, I guess there might be cohort studies where you sort of know, what % of people are able to return to work by a certain time frame. And I guess if you've got the evidence, you'd put it in. So the same principles for patient decision aid apply as for evidence-based practice in general, is that you use the best available evidence. And it may not be the ideal evidence because that doesn't exist yet. So whatever's the best available evidence at that point in time, you would try to incorporate into the decision aid. Failing that, if it doesn't exist, nobody's done the research yet, then you, as I said, same with EVP, you go down to, well, based on expert opinion or case studies, or whatever's the best available
level.
That's right.
Yes.
So it sounds like that decision, there'd be more pragmatic stuff to weigh up. Than evidence-based, but that's okay. Sometimes just setting out the options for patients and helping them, having a list of all the things to think about, to help them process that decision and make an informed decision, rather than going with this sort of initial prior expectation or gut, or what someone else has told them is the best thing for them to do.
Yes, exactly. So these athletes that I think of, and in both cases, are typically young, under the age of 25, and I've been asking them to consider the 50-year-old that would sit in front of me as a result of that decision. And I don't know, do you think do you think it's a good idea? Because I see these young kids, they want to go back to sport. Being involved in that community is incredibly important to them, but it also comes with risk, doesn't it? I'm thinking, we're from New Zealand, it's a very contact collision sport atmosphere here. And so I asked them to consider the 50-year-old version of them.
I don't know of any research that's looked at how accurate, what effect that has. I think it would be tricky for people to put themselves a few decades forward in time,
Yes. Is there any other tips then you have around dealing with younger people? Because that younger people think maybe the decisions are more I guess these decisions affect their lives, don't they? And we
absolutely.
as clinicians,
and that is something it sounds like you're doing a great job in saying, this is how you can talk about the short-term benefits versus the longer-term benefits. and the
Yes.
short-term harms or cons and the longer-term harms. So I think just presenting that, whether that's, you know, enough to help folks sort of truly put themselves 2 decades forward in time, and
It's
the old
hard to
saying about
imagine.
we
Yes.
live life forward and understand it backwards, and
Yes, exactly.
things we done differently a few decades ago, I would apply here as well. But certainly spelling out that, in the short term, this is what both options or the various options might look like, but longer term, this is what it
Mm,
might look like if you go down either path. Yeah.
mm. And what's the evidence? I'm really enjoying talking to you about this because what's the evidence around people then having made that decision, then accepting the pros and cons of that decision afterwards, once you've been through this process? Is it different?
Yeah, so that's a concept called well, there's a few constructs. There's one called decision regret, which is
Yes.
where there's quite a lot of research looking at the extent of decision regret that people have either
Mm,
after going through shared decision making or not. And we know that people who have gone through a shared decision making process tend to have lower levels of decision regret.
yes.
And that's one of the main reasons to be doing it, because particularly
Yes.
where it's irreversible things like surgery, where you don't want to have gone down a path and then, you're not getting the recovery is not what you expected, or it didn't achieve the goals you thought it might. And you think, oh, I really wish I hadn't have done that.
Mm, mm.
So there's certainly literature showing that shared decision making reduces decision regret.
Which is good to know, isn't
Absolutely.
it?
And it also reduces decision or conflict, which is shortly after making a decision, or even at the time of how conflicted do I feel about the decision, or the flip side is how comfortable do I feel with this decision? Do I
Yeah.
feel like it aligns with my values and my preferences? Do I feel like it's the right decision for me at this point in time? So we also know that shared decision making reduces decisional conflict.
Right, which is then how they feel about the decision that they've
That's
made.
right. How comfortable
Yeah.
they feel, with it. Yeah.
It's fascinating, isn't it? There's so much to think
It
about.
is. It certainly is. Yeah, absolutely. Yeah, and it's a fascinating
Do
area for.
you have any tips for clinicians how they could do this better? How they, because there's obviously all these concepts and phrases that many of us aren't even aware of. Is there anything else you think clinicians need to be aware of?
I think view shared decision making as a skill that can be learnt. So it's
Mhm.
not, just you can just read up on it. Certainly, some of like the
Yes.
paper you spoke about that you read here, we give some examples of the phases of shared decision making and how to do it. So read up on it. I can suggest a few other resources for you, like textbook chapters, or there's
Yes.
a free online course I've developed with some colleagues, which takes you through shared decision making, gives you the chance to run through, they're not physio examples, unfortunately, they're medical ones, but gives you an
Mhm.
example to have a go at how you'd answer, how you'd phrase things to patients, or
Yeah.
what might be the most appropriate way. Because one of the trickiest things is learning it's the step called the risk communication, which is how do I describe the evidence in a way that's simple and that a patient's likely to comprehend. So yeah, learning some particular skills in that is valuable. So I
Yeah.
can send you some resources if you want. Yeah, there
Yeah,
are
that would be
free
wonderful. And
resources
I
where, a skill,
people could
like with
access.
any clinical skill, it's a skill that can be learnt. It's not just,
Yes.
most people can't just say, oh, I want to start doing shared decision making and do it beautifully the first time. Um,
Turns out there's all these phrases and things at the risk communication that I am probably not doing well and we could improve,
Absolutely.
you
And we
know?
know sort of some of my work has been in training undergraduate and postgraduate students and clinicians in shared decision making. And we know that if they see it modeled, if they see a role play, they find it, easier. If they initially, when they're learning, if they learn a few phrases or phrases they can kind of use while they're getting the hang of it, and then they can
Like what?
start. Well, things like, do you have enough information to make a decision?
Yeah.
Just sort of prompting yourself to think, to ask that.
Yes.
Um, and once they've learnt those few phrases, then, they'll obviously adapt it to their natural
To their
consultation
language,
style and
yeah.
things like that. So we try to we advocate for learning these skills early on in a clinical career, ideally in the undergraduate course, and it's now part of some, not all, but some undergraduate courses, before all those consultation habits and phrases are established, so that this is the way we do things.
Yeah, and that's the process, and it's then just part of the process, not like me, who's now a little long in the tooth, adapted to that. And
sorry, I wasn't agreeing with you there. I'm just saying that there is a whole generation of clinicians who, you know, this didn't exist, or it wasn't taught 20, 30 years ago. So, you know, they now are needing to learn. Same with evidence-based practice. It was, you know, implemented. There was a whole generation or two who needed to sort of upskill in it. We did a paper in the Medical Journal of Australia about 10 years ago where we tried to really simplify it. If you sort of wanted to remember 5 key questions to prompt yourself to do shared decision making in a consult, it would be, you know, saying to the patient, you know, what would happen if you wait and watch, and presenting that. What are your test or treatment options? What are the benefits and the harms of those options? How do those benefits and harms weigh up for you? And do you have enough information to make a decision? So a very simplified version, but sort of a 5 key questions to try to integrate into a consultation somewhere. And then you're getting the, you know, the core bits of shared decision making.
Yes, and those are really important take homes for clinicians, aren't they, to think about those concepts. I guess that do you see clinicians make particular errors, or is there some things that clinicians, how should we say, aren't optimal in this space?
So what we see is some of the biggest barriers is actually thinking they're doing shared decision making when they're not, and we've had a lot of clinicians that who'll say, you know, we've audio recorded their consultations and we've analyzed them, and then we say to them, you know, how do you think you went? And they say, oh, I'm a great communicator. And so they conflate it with having good communication skills. But as I said at the beginning, it's more than just the communication skills. You need that, absolutely. But then it's adding another skill on top of that. And I think some of the others, I don't like to call it mistakes, but sort of they're the myths about shared decision making that prevent people from learning about it or doing it is they'll think that it'll increase the duration of a consultation. So particularly for a lot of our workers with, you know, like general practitioners in, you know, time limited consults, and there's that perception that, well, I don't have time to do shared decision making. We know from the evidence from various systematic reviews that the increase in time is minimal. Some studies show a slight increase, some studies show a decrease. I think the latest estimate, the latest systematic review showed a median increase of 2 minutes per consultation where shared decision making was done. And some clinicians find that it actually helps them structure the consult more efficiently, so that they don't get to the end and then, you know, realize there's a chunk of information they haven't sort of conveyed to the patient. And I think another myth that prevents folk from giving it a go or offering it is, oh, patients they won't understand the information. They don't want to be involved. They're happy to do what I tell them. I'm the expert, which is not the case. There's plenty of studies showing that most patients, I think it depends on the setting and the context and the country, but about kind of 90% of patients want to be more involved in decisions about their healthcare, and they can be certainly, you know, the information can be conveyed in a way they understand, even folk with, you know, low health literacy, and there are ways to do it. So all those sort of perceived barriers to it or reasons for not doing it, or at least not even offering it, we can refute those.
Yes. Any tips around the low health literacy then?
Yeah, so that's, so as I said, there's some resources I can refer you to for that. But so that's about simplifying the presentation of information even more, and also using, you know, the proven health literacy strategies like the teach back, you know, can you tell me what you've understood about what I've just said, and checking that there hasn't been any misinterpretation. And again, supporting with appropriate written materials that have the right readability level and all of those things.
Mm.
So, yeah, so there's some particular strategies around when working with people with low health literacy.
Yeah, so much to do in this
So
space.
much to do, but so important.
I completely agree with you. Just to finish then, Tammy, is there anything you think is important for clinicians to take away? Like there's obviously, you're going to send me through some resources that I can put then in the show notes, and that people should engage in this process and try and use it as a process rather than an add-on, is what I'm hearing from you.
Yeah. I think, as we know that most people want to be more involved in their health decisions. And if you think about yourself or, your family members when they're faced with a health decision, do they want to be involved? And yes, the answer is yes, they do. So
Yeah.
put yourself in that, your patient's shoes. They will nearly always want to be more involved. So it's about providing that invitation to be involved and, letting patients know that you're welcoming their involvement and you're actively supporting it. And then just presenting that information clearly and supporting them to make an informed decision. And that and I guess the other bias to check is that there's no right decision. So often a clinician thinks, well, if it was me, this is what I'd do. Clearly, that's the right option.
Yes.
But that is kind of the opposite of shared decision making. It's realizing that as long as the patient has understood the options and the benefits and the harms, and they've considered what's important to them, like what matters to them,
Yes.
no matter what decision they pick, if it's an informed one, that's okay. If that's their decision, that's okay. Even if it is different to what you would pick if you were in that situation.
Yes.
That is
Yes,
okay.
which is some of my young kids going back to rugby before I want, that is, and I'm learning to step back from that.
And that can
like,
be tricky when you think, oh, I don't think that's the right decision. But as I said,
yes.
this is the whole concept of patient-centered healthcare. It's
Yes.
as long as it's an informed decision that, they've been clearly explained the options, the benefits, the harms, thought about what matters to them. Whatever option they pick, if it's an informed one that aligns with their values and preferences, that is okay. It's not like it's the wrong decision. It's the right decision for them at that point in time.
At that time. Yeah.
And being okay with that, which can be challenging.
Yeah, God, but I've learned such a lot from you, Tammy, in this discussion. So thank you very much for your time.
You're most welcome.
I really appreciate it, and I appreciate there's lots of clinical gems in here for clinicians to take away that will help their patients to make better decisions. So I really appreciate your time. Thank you.
No problems. My pleasure.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.